Welcome, Dr. Donna, to another episode of Dynamic Dialogues. I'd like you to take a minute to introduce yourself.
Yes, thank you, Esraa, for having me on the episode today. So my name is Dr. Donna. I'm a physiotherapist. I'm a specialist in musculoskeletal rehabilitation and pelvic health. And for those of you who don't know, musculoskeletal rehabilitation is everything to do with like head to toe. So it's the whole muscular system, skeletal system, and the joints. And as a subspecialty, I do pelvic health, which includes rehabilitation and looking after the joints and the muscles in the pelvic region.
Mm-hmm. So today's episode, I want us to go over pregnancy, prenatal care, as well as pelvic floor care for women that have never been pregnant, the nulliparous population. So let's start with a few questions because we've got some of our viewers have sent us some questions and I want to go over them one by one with you. Let's first start with women that have never been pregnant. Mm-hmm. One of the questions that came up was, are there any circumstances where pelvic floor exercises should not be done, or are they suitable for everyone?
Okay. So before we dive into that specific question, maybe it'll benefit the viewers just to understand a little bit more about pelvic health and pelvic physiotherapy. So basically in pelvic health, we look over the entire pelvic region. So that's the bones that hold the pelvis together. The bones are connected to our lumbar spine, which is our lower back, and it's connected to our legs. And all of the organs that sit in that region, which in women would be the uterus, the bladder, and the rectum. And obviously on top of it's our abdominals. So if you think about that region, there are lots of things there. There are lots of organs and lots of things that could possibly go wrong as well. So to kind of go back to that question is pelvic floor therapy for everyone? And as someone who's never been pregnant, do they need to look after their pelvic floor? Well, I would probably say yes, because of the number of organs there and the number of things that go wrong. So obviously the younger you are and just before you get pregnant, you are probably less likely to have any of these conditions, but you're not necessarily immune to them. So the set of problems that come with pregnancy and delivery are their own set of pelvic health conditions. But for someone who has not had these experiences yet, they could still suffer with some mild problems or even severe problems of trying to control their bladder, which is controlling their urine, and possibly controlling any of their other orifices as well in that region. So the rectum and like going to the toilet and doing their number twos. It's not very, very common, but it can be. So if you're lucky enough not to have these problems, and you shouldn't at that stage of your life, you still need to look after your pelvic floor, because if you're exercising regularly, if you're lifting weights, you need your pelvic floor to be strong, because your pelvic floor is the base of your body, basically. It's the base of your lumbar spine. So if you're a very active person, you go to the gym, you do a lot of high impact sports, you need that base to be really, really strong so you could build around it. So you could build your abdominals, you can build your lower back, you can build your buttocks, your glutes, and even your thighs, so your quads and your hamstrings. So yes, there should be an awareness about the importance of the pelvic floor at all stages of women's lives. Other examples could also be some women, if they have any hormonal problems, for example, any problems with their periods, missed periods, long periods, period pain, we might want to look at their pelvic floor as well, just to make them a little bit more comfortable.
I want to stay within this space right now. And let's talk about women that have never been pregnant, the nulliparous demographic. Now, you discussed that it's very unlikely, or maybe there are a fewer percentage of women that do
Less
suffer
likely, we'll say,
with pelvic floor issues. Let's talk about the women that do struggle. Would you say overweight women, women with PCOS, perhaps?
So a little bit more about who might suffer.
Yes. Yeah. Who would you suggest? Yeah. Who are the people that you think would probably suffer most with pelvic floor issues? That's one. But also, I'd like to talk about what you just said with regards to the training. Yeah. So more and more women in their teens and 20s are training. Yeah. And like you said, the pelvic floor needs to be strong enough. But I also like to use the word responsive.
Yeah.
Responsive to the load. And I feel it's very important for us to share this with our viewers that the pelvic floor is a muscle.
Yeah, it is a muscle.
It's a muscle.
Yeah.
And just like any muscle, it needs to lengthen and stretch in order to contract.
And tighten when it's needed.
When it needs to contract.
So
if you can shed a little bit of light in terms of, one, what type of women would suffer from certain pelvic floor issues, and what kind of pelvic floor issues would that be?
Yeah.
And two, how would, let's say, training, lifting weights, high intensity training, how does that impact pelvic floor health?
Yeah. So with regards to your first question, so who would suffer from these conditions? Obviously, you mentioned overweight and obesity. Obviously, we know that being overweight and being obese is a predisposing factor to many diseases and many problems that are induced by lifestyle factors. So unfortunately, yes, women who are overweight or obese are probably at higher risk of having problems with their pelvic floor. But we can say that there's very specific reasons why. So first of all, like we said, the pelvic floor is the base. So the more you pile up on that base, the more the load on the pelvic floor. So your pelvic floor theoretically needs to be stronger than someone who isn't overweight or obese because it's doing more lifting, for example. So yes, theoretically, it could predispose you to more problems then or later in life. The second thing is, and unfortunately, most women who are overweight or obese, most of them are also less likely to be very active and less likely to go to the gym and exercise. We can't say that's the case for everyone because we know there are lots of women who do try, and it's an overgeneralization. But if you think about it, the less active you are, the more sedentary you are, the less likely you are to exercise. Your pelvic floor doesn't move very often, so it's sat down, it's sedentary as well. So the muscle is likely to be weaker. So these are the main two problems. There are some other conditions that could trigger some pelvic floor symptoms in this set of women. First one being, which is probably a little bit unknown, but stress and anxiety can cause incontinence, and specifically stress urinary incontinence. So stress urinary incontinence is when there's a stressor and you feel the urge to urinate or you're unable to control your urine. And these stressors are commonly physical. So people refer to them as a cough, a sneeze, a laugh. However, anxiety, depression, low moods, and just general mental stress is also a physical stress. We know that mental stress causes physical effects on the body. So I do actually deal with a large group of even teenagers. They're not, I wouldn't even say they're young women, they're 20s, a group of teenagers who are undergoing a lot of stress in their lives. And sometimes it's just things to do with school, excelling at school, being a perfectionist. And these girls, let's say, do have weak pelvic floors or overactive bladders. The other one, which is technically strictly a lifestyle factor, but the intake of caffeine. The more caffeine you drink as a young person, the more likely you are to have an overactive bladder and a weak pelvic floor. And that's caffeine from coffees, tea, kerak in our culture, chocolate, sugar. We depend on a lot of caffeine in our culture.
I do want us to stay here because I have a whole list of questions that I wanted to go over with you with regards to urinary incontinence. So I'm glad you brought us here. With regards to, let's go over stress urinary incontinence with the younger population, like you mentioned. Sometimes, it's very different. I think it's very important for us to distinguish between urinary incontinence led by just, let's say, the inability of the pelvic floor to, control the bladder.
So like a functional problem.
Functional problem versus an urgency problem. Because I think a lot of viewers are not aware of this fact. There's an urgency issue, and then there's the control issue.
And there's a mix as well.
But I really want us to kind of, kind of delve in that a little bit. And also what you mentioned about the caffeine. So in our culture, Diet Coke, coffee in general, like you said, kerak. There's a really, as well as green tea. A lot of people thought green tea is...
people don't know that green tea has caffeine.
Green tea has caffeine,
I think, correct me if I'm wrong, but green tea has more caffeine than like red tea.
I think so. think so.
Yeah.
I'm not really sure, but I think so.
Yeah.
Now, that's the thing. These are all factors that would contribute to, I guess, both issues, but more so the stress urinary incontinence, which is the urgency to pee. And I think a lot of younger population do struggle with this urgency of not being able to, like, the need to have to use the bathroom more frequently. Yeah. Now,
part of it's habit as well.
Yes.
Like some people have a habit of like, I'm going out, so I need to go use the toilet, even though I've just used the toilet.
Exactly.
Or, you know, I'm in a shopping mall, I'm not going to use the toilet, so I'm going to hold it all the way back home.
Which brings me to my next point, bladder training.
Yes.
And I feel like a lot of people are not aware that bladder training is a thing.
Yeah, because your bladder is a muscle at the end of the day.
Exactly.
So you can train your bladder the same way you train any muscle. So you could put it on a schedule, it gets used to things. And obviously, the longer you hold your urine, the stronger the muscle becomes because it's time under tension. So the tension comes from the amount of volume of urine in the bladder. And then it's just getting stronger. So yeah, there's, like you said, there's lots of different types. So if you want us to clarify again, so stress urinary incontinence is something that so incontinence technically refers to actual leakage, so loss of urine.
Yes.
So it's when there's any physical stress on the body and there's a little bit of leaking. It could also be complete loss of urine, so everything comes out as well. Urgency is the need to go to the toilet as well. And it's the need to go to the toilet when you don't need to go to the toilet.
Yes.
So obviously, it's normal to feel like you need to urinate because your body's linked, your bladder's linked to your brain to tell you when you need to go to the toilet. It's a problem when your body's telling you need to go to the toilet, but the amount that you release in the toilet does not match that sensation.
Yes.
So it's a couple of drops or let's say 100 mLs compared to you feeling an urge, like a big urge to go.
Yes.
It only becomes incontinence when you're unable to control it because of that urge. Like
I read that a full bladder can take up to 500 ml.
Yeah, I think you can take
water.
even more.
Yeah. But like a healthy full bladder, for you to empty out your bladder, ideally should be at around 500 ml. When I was pregnant, my biggest fear, because I was one of those people that had the stress urinary issue where it's like, I don't, because I hate public bathrooms. Yeah. I think most women relate to that. Yeah. No woman likes a public bathroom. So it's like you go out of the house and you're like, you know what? I'm just going to go pee just in case and then make it back. Yeah. And what I didn't realize at the time, because I don't know what I know now, is that I trained my bladder
to hold it
to
for a
hold
long time.
a lot less urine than it was capable of, because
so
I kept
exactly. So you trained your
going
bladder
to the bathroom
respond,
just in case,
exactly, to tell you that you need to go to the toilet when it's like half full, basically, maybe, or even a quarter full. And actually, you could even do the opposite. So if people hold it in way too long, they could train their bladder to hold in way too much urine, and then it becomes really difficult to like control. So you see them. They've held it in for hours. They've gone to like city center. They've come back in traffic. And as soon as they go through the door, they have to rush to the toilet because it's like 8 hours of urine accumulating and a couple of coffees in there as well.
Funny story.
That have made it irritable.
So funny story. I thought I've heard this amongst a lot of women. So whenever women go to a changing room at a department store and it's time to get changed,
they feel the urge.
Yeah. And I don't know if it's the cubicle.
It's probably because your body is trained to relax in a certain way. So maybe undressing or being on your own, it probably gives you that let down effect. So your body thinks it's preparing to urinate. And obviously like just a tactile sensation of maybe zipping, unzipping trousers, jeans, lifting, unlifting your clothes.
Because the first time I heard about this was actually, I was watching, I don't know if you remember the show Big Brother in the UK.
Yes.
And it was one of the guests on in the Big Brother house that mentioned it. And I'm like, actually, never thought about it, but it does make sense. So we had this discussion with our friends and they all related. They're like, actually, we all have the same problem. Yeah. And I thought it was very interesting.
Yeah. So the interesting thing is as well, like of the different types of incontinence that you could suffer with, if you train your bladder to hold in the urine for a very long time, You could also get tension in the pelvic floor. So some women, like you said, in your case, you trained yourself to go more frequently and your body was responding to smaller amounts of urine. Women who hold it in for a very long time end up having a really tight pelvic floor.
Yes.
Because their pelvic floor is just strained. It's trained to close for long periods of time. The pelvic floor muscle becomes tight. It can also be painful. Like it could also radiate some pain into the groin, into the hips in some instances. And these women also have a sensation of when they actually go to urinate, they feel like it's really difficult to initiate. Like they need like a minute on the toilet to kind of relax. And some of them tell me that they have to push. You shouldn't push to pee.
Yeah, no.
So when you get to a point where you're pushing to pee, your pelvic floor is really, really tight.
Yeah.
The same group of women might complain of something called incomplete emptying as well. And actually that's very common with people.
Isn't that related to prolapse a little bit as well?
To some extent, yes.
Yeah, okay.
But so it all has to do with your anatomy, where things end up. So in a prolapse, things don't end up where they're supposed to be. In a tight pelvic floor, things aren't where they're supposed to be. So basically what happens is if your bladder just fills up, okay, and you're emptying, it's too tight. It doesn't open completely and it doesn't release all of the urine. It closes up faster. You think you're done. You stand up, you move around, and then whatever fluid is just dropped down, and then you feel like you need to empty again.
Yeah, and that's very common with a tight pelvic floor.
Possibly more common. And then people usually come and tell me, oh, I've just been to the toilet and I've had to go again. That means I need to go very frequently. So it could be a combination of like urgency or a combination of an incomplete emptying, a type of a different incontinence. And that's why we always tell women, you have to get things assessed because it's not that straightforward. Continence and incontinence is a mixed bag. Yeah. There is an effect of the rectum as well and what the rectum is doing on the rest of your body. And like you've said, prolapse. But again, if we're thinking of the younger, again, if we're thinking of these younger women who haven't been pregnant or maybe with their first pregnancy, they're unlikely to have a prolapse. But yeah, doesn't mean that they're unlikely to have problems with their rectum. If this group of women have suffered with constipation their entire lives as well. So constipation, again, is a predisposing factor for problems with urinary control in early adolescence, in your 20s, and even later on in life. Other women, if we can think of, not related to pregnancy. I can just visualize
our younger viewers cringing at the moment, going, why are they talking about constipation?
It's cringy, but someone has to tell them.
Exactly.
Yeah. So it better be me. So yeah, there's, again, not to get sidetracked, but there's a lot of work going into educating women, at a much younger age.
Honestly, I think we should. Yeah. We should educate them. The younger, the better. Because if, let's say we're lucky enough to have a few young viewers watching this episode, I think, can you give them like a takeaway from what you just said?
So if you're younger, or let's say not necessarily younger, but say in your early 20s or even in your 30s, but if you think you're not married, you haven't had like marital relations, you have not been pregnant, don't worry about asking people about symptoms that affect your pelvic floor. People always think that pelvic health or women's health is for women who are pregnant or married or older. Actually, no, looking after your pelvis, even like non-muscular problems like your hormones, your hormone health, all of these things. This is for all women and girls. So if you have a question, go see your OBGYN, go see a women's health physiotherapist, go see, if it's just to do with weakness, see someone who's a specialist in like training women, for example. The take-home message would be, it's better to ask than deal with consequences later in life. Because the younger you are with tackling issues, the more your body will respond. And again, if you are planning, like we say, inshallah, one day you'll get married, one day you'll have kids, isn't it better to tackle these problems now?
Absolutely.
Than, when you're having your first pregnancy and you realize you're having control issues with your urine 3 months in or 4 months in when the baby starts to grow. Yeah. And you're like, ooh, that pesky bladder of mine is now really acting up and it's limiting my life and I'm not enjoying my pregnancy. So why didn't you say something before,
Like in my experience, so like I mentioned, for years, just due to my hate for public toilets,
Yeah.
I always made sure I emptied my bladder prior to leaving, any room I'm in. Like whether I'm at work or I'm at home or family's house, I'm just like, okay, before I leave the house, I need to make sure, even though I didn't have to go. So over time, I had that urgency issue, which was stressful in itself.
Yeah.
So when I got pregnant, I'm like, oh no, I'm going to have a baby pressing on my bladder
The whole time.
and this is going to be rough.
Yeah.
And the second when I found out I was pregnant, that drove me into diving headfirst into everything prenatal, postpartum, pelvic floor, to take care of myself.
Yeah.
But also, I've always had an interest in it. But it's different when you're the patient or you're the client and you're the one going through it.
So interesting story. So one of the reasons I actually took a dive, a subspecialty into women's health was after I had my first baby. So I was more of a generic musculoskeletal physiotherapist, and I worked in more with chronic conditions at that point. And I was really interested in the lumbar region and the pelvic region as well. So still pelvic, but I was more interested with the back of the spine, the lower back. And then after I had my son, I started sympathizing a little bit more with women who'd complained of some of the symptoms I started noticing on myself. So actually that's when I took it upon myself to expand my horizons and improve my skills, and I subspecialized because exactly as you said, some of the things I was really interested in knowing to help myself. But then I was just like, if I work in this profession and I can't help myself, how are other women coping with this? So that was a light bulb moment for me.
It is a very challenging. Some women are luckier than others. Like I have friends that had no problems whatsoever. But obviously, in our society, there are some topics we don't talk about.
That's very
so whether
true.
they do struggle with this or not, I wouldn't know, because would it be something that they would openly discuss?
I think it's a combination of things, Esraa. So the first thing is, like you said, some topics are a bit taboo and you don't discuss them. Probably more with the older generations. Like I'm hoping the more,
but I feel
our
like
generation
with some
of moms
women as well
now,
that want to maintain a certain image.
Yes, that's true.
It's
and that's everywhere.
Yeah,
that's everywhere.
Whether it's here or else, anywhere else in the world. I mean, a woman is going to want to maintain her image, and having to talk about such topics is just not in line with the image that she is trying to portray.
The other thing is, one of the reasons people might not talk about it is because they expect it as part of the pregnancy journey and as part of, going through the motions of being pregnant. It's normal.
It's normal.
But I really love that you bring this up, because what's normal and what's not normal. So another kind of key message is to actually understand what's normal and what's expected, and what actually is, no, this is not normal, So it's normal to have changes to your pelvic floor when you're pregnant. It's normal to have some form of incontinence midway or at the end of the pregnancy, obviously. I would probably say it's probably uncommon not to have any symptoms in your pregnancy.
Right, yeah.
And if you do, then,
So
really lucky, I guess.
So what I was trying to say earlier was, with my experience in my pregnancy, was when I first got pregnant, like I said, I went head first, and I'm like, nope, I need to get ahead of the problem. And that was the mindset I had. I'm getting ahead of the problem. Let's see what I could do to avoid it, because I wanted to stay active right till the very end. First thing I did was, obviously, I think I came to see you.
Yes.
I came to see him. I was like, okay, doctor.
Yes.
What's the damage?
Halfway through your pregnancy.
I was halfway through the pregnancy as well at that point. And then I saw a childbirth educator, because I needed to know, okay, what's happening with my body right now? What am I supposed to expect closer to the birth and all of that? And honestly, best investment of my life. And then I realized, okay, I need to start being active. So I, got some programs from pelvic floor therapists that, like prenatal programs that I followed. And it really did help. I walked a lot. And the one thing that stuck out, because I used to be too afraid to drink a lot of water, because I'm like, but I'm going to be on my walk. And what if I'm out there in the park or somewhere walking and I need to use the bathroom? I mean, what am I going to do? But then most of the research I did highlighted one very, very particular point.
Drink your water.
Drink your water, because the less water you drink,
the worse it's going to be.
The worse the urgency, the urinary urgency is going to be as well.
Put yourself at risk of infections,
of course,
and dehydration,
yes. Absolutely.
and just, mess with your blood pressure and all of that stuff.
100%. So I drank the
yeah.
water. I was like, right, I'll drink the water.
You probably reversed it to some extent.
I did. Because 100%
Yeah.
I did. And by the end of it, I remember I was in the States, and right till the very end, I had a step goal. I'm like, honestly, I was more on it during pregnancy than after. We'll talk about postpartum another time. But it was like 11 p.m. and I had a 12,000 step goal. And I was like, telling my sister,
11 p.m. Wow. Yeah.
I'm gonna go for, is it safe to go for a walk in this cul-de-sac? She's like, yeah, it's fine. Just call us.
Yeah.
Take a torch. I was like, fine, take a torch. I was like, what am I going to do? Someone tried to attack me. Hit him with a torch. But I didn't care. I was like, okay, I'm going to go out. And at that time, my friends in Bahrain were awake. So I'd do all my phone calls during my walks. So I would walk. And I remember it would be like around a 600 meter, like a 600 meter lap around the cul-de-sac. And then I'd go in because my bladder was full. Empty my bladder. Get out again, go for another.
That's the thing.
And I tried to push it as well. I'd be like, okay, no. I'm going to go for 2 laps because I don't really need to go. So focusing on training my bladder was a priority.
But see, that's the thing. Like, again, what's normal and what's not normal.
Yeah.
So at that point, walking, 600 meters, has that like 5 minutes or 10 minutes?
I think it was a bit more than.
Okay, let's say 15 minutes.
Yeah.
Okay. So, at that point, with someone towards the end of their pregnancy, there physically is a big baby pushing down on that bladder.
Of course.
And everything's expanded. There's a lot of blood volume as well in there. Yeah. Your organs are swollen to some extent. Your bowels are on top of each other. There is actual pressure on that bladder.
Of course.
And you're walking. So you're in an upright position. You're walking. So things in your pelvis are just shaking, aren't they?
True.
So it is normal to feel that need to urinate. And I think this is what it's good to highlight, what's normal and what's abnormal. And actually, one of the ways you need to train and improve bladder control in general, rather than just, counting these laps or whatever. Sometimes it's a bit mental as well, and say, okay, so what if I don't go to the toilet? What's going to happen? And I know most women hate it when I work with ladies who I just need to kind of regulate their control, and we keep things like bladder diaries. I'll talk a little bit more about them and say, just leave it and see what happens. They hate it because they think they're going to have an accident and leak. They don't, because a big part of it is just mental and psychological. And there's actually a lot of evidence that at that point, when you're stressed and you think you're going to urinate, there's a lot of work going on in your neurological system that's actually pushing on that detrusor muscle. So the detrusor muscle is the muscle in the bladder inside your body. It's the one that pushes the urine out from inside rather than opens the pelvic floor to empty. So there's one from the top and one from the bottom. When you're stressed, the detrusor squeezes it a little bit more. So one of the common relaxation techniques is we say, okay, stop, distract yourself first. And if you can distract yourself, take deep breaths, and actually deep breathing, because of the oxygen and CO2 exchange, dampens down that nervous system and takes the pressure off of the detrusor. So it buys you a little bit longer.
Would you say this would also apply to perimenopausal and menopausal women? Because I have a few clients that are menopausal, I would say, and perimenopausal, that are struggling severely with urinary incontinence. They never had the problem before.
This example you've given me, like the urge to go, works for anyone, regardless of age, regardless of the actual pathology or the problem that's causing this. So if we take this as a symptom, not the underlying problem, which could be menopause, prolapse, pregnancy. So forget the underlying problem. We're looking at this as a symptom.
Right.
If this is the symptom, and we know that this female has not drank an excessive amount of fluid since she's last urinated, then it's worth trying it.
Right.
It's only going to fail when, in the last hour, you've actually drank a liter of water. So it's probably a true need.
Yes.
And I said I'll come back to the bladder diary, but with women where I've eliminated many reasons for their urgency. Yeah. Like a disease or whatever, we've eliminated everything, and we think they have good control as well of their bladder. So interesting thing, you could have good pelvic floor strength and still have these symptoms.
Because that's bladder control.
It's kind of physical and mental at the same time.
Right.
So we keep a bladder diary, and in the bladder diary, I make them write how much they've drank, how much has come out, and the timings as well. So I'd be like, okay, go back to your bladder diary. You've peed half an hour ago. Since you've last peed, you have not had an excessive amount of drink, liquid. Is it logical for you to feel this urge to urinate now? If the answer is no, try the relaxation technique.
Right.
If the answer is yes, in the last half an hour, I've had a double shot latte, I'll be like, okay, maybe. Yeah. But then I'll be like, why did you have that double shot latte? You know, if you're having problems controlling your pelvic floor, we'll be working on your caffeine intake as well.
Of course.
So the client or the patient, you really have to work with them. And that's what I'm saying. Like, how many
That's the first thing I eliminated,
exactly,
by the way,
how many types
for my clients. I was like,
incontinence
control your caffeine.
How many types of incontinence have we mentioned so far? So many.
So many.
So the stress, the urgency, the overactive bladders, the combination, the incomplete emptying, the irrational need to go.
And there's a misconception that I really want to highlight here. There's a misconception that urinary incontinence is only for people with a weak bladder. And there's also another misconception that a tight bladder means a strong pelvic floor, and a weak bladder is a weak pelvic floor. But what a lot of people don't understand, that in both cases, which is hypertonic and hypotonic pelvic floors, the symptoms are very similar, with the exception of like pain during sex with a hypertonic pelvic floor versus a hypotonic.
Actually, interestingly enough, with a weak pelvic floor, you could still even get pain during sex because not everything's held in place, and you know, women feel a bit loose or not in control again. So yes, I think the trick is to understand the type of symptoms you have. The trick is to know what's normal. So when you think there's something abnormal, to come and seek help. Right. And there's a lot going on, and I think again, I think this is one of the things we were discussing, you know, is Keigels the only answer? Yeah, actually, is that one of the questions?
Let me go through. I feel like there's so many questions here that we have not covered, and I do want to.
So people keep asking me, am I just going to come and we're going to do Keigels? I was like, Keigels is the basis of our therapy, but I'm not just going to get you in a clinic setting.
So the question here that we've got actually a couple. Pelvic floor exercises, does that mean Keigels? And if so, how does one know they're doing them correctly? That's one. Yeah. And two, are Kegel exercises legit? Yeah. And how many times should we do them to see results? And then the next question is about waist trainers, which we'll get to another time. I think this
needs its own podcast me to talk about Keigels.
It does. But also another, and I think there's a very smart person who sent me this question. Is there a connection between the pelvic floor and the abdominal muscle? Now, you and I know that there is very much. It's one. It's one, or like, to me, I look at it as one organ. You know, that's symbiotic. It works together.
Because there are a lot of overlapping attachments.
But please shed light on this. Is there a connection between the pelvic floor and the abdominal muscle?
Keigels first. And I think Keigels were created by someone called
Keigel,
yeah.
A man,
obviously. Finding a solution to all women's problems.
Exactly.
So basically, Keigels is Mr. Keigel's name, and he discovered that basically squeezing your your urethra close and shut and squeezing your vagina could help tackle some of these symptoms. Now, that's the basis, I would say, of treatment. So yes, we need to know that you have power and ability to move that pelvic floor, and we need to know that you're doing it right. So in terms of how do I know if I'm doing it right? And I think this is where there's a role for like face-to-face interactions, and there's a role for physiotherapists to work in these conditions. Because if you told me, how can I do like a bicep curl? I can just show you and be like, okay, you know, you could do like, you could just lift it, literally bend your elbow in lay terms, lift up that weight, and you can see it. I can see it. You can feel it. Unfortunately, we shouldn't be showing each other how to do Keigels, but someone with knowledge of how to perform Keigels could help facilitate that movement for you. So there's different ways to doing it. And as a physiotherapist who's highly qualified and trained to deal with the pelvic floor, I can actually spot Keigels externally at this point in my career, thankfully, because not everyone wants an internal assessment. So we are taught to visualize key cues on a female body and see the rise of the skin and bony landmarks to indicate whether there's a Kegel contraction or not.
Okay, I'm going to ask you a question.
Yeah. What do we look at?
No, wait. Are you saying... Okay.
Not when you're sat down and dressed.
Okay. So that was the question.
Yes,
so
no.
they're laying down,
Yes.
and
so these are intimate areas.
Okay.
So the female needs to be relaxed to be in obviously an individual intimate area.
So you have a view of the organ itself from the outside.
From the outside,
and then you are looking at the organ, and you'll know. You can spot a Kegel.
So we can spot some of the creases externally around the rectal region. We can spot the perineum region as well, which is external. And we are trained to see the perineum lift. And as the perineum lifts, you can see the sides to the groin as well. So the folds in your female intimate areas will fold to some extent.
Can you tell? Because obviously, like you said, there's your rectum, you've got your
vagina.
Is it urethra?
Urethra, yes.
Urethra, yes. So basically, can you tell what part contracts more?
Yes.
Just by looking at it?
Yes.
Okay.
So we are trained to identify that. Obviously, it's not something that comes overnight, but we are trained. And we see high volumes of women as well. So we know what's normal and what's abnormal.
When I mentioned earlier that the pelvic floor, as well as the abdominal muscles, function as one organ, I've noticed that when women say Keigels, they are just focused on the pelvic floor without taking into consideration the entire kinetic chain.
They don't understand
the Kegel is just the base, the base of this kinetic chain. We have to incorporate
Absolutely.
all the muscles within said kinetic chain.
So again, to go back to like what is a Kegel and how to do it. So there's the external way, which is incredibly useful because obviously in our society, it's not acceptable for everyone. And we completely sympathize, and it's okay to do an internal assessment. Now, obviously in the West, an external assessment is not seen as enough or as specific, but we have to use our tools when we can. A more intimate assessment internally of the vaginal walls is the gold standard, okay? And obviously it's female choice, and I'm for both of them. I think there's room for both of them. So that's the best way to know if you're doing it right. The second thing is, yes, do we need to connect it to the rest of the body? Absolutely. Generally, women who have weak pelvic floors are more likely to have weak abdominals anyway, weak gluteals. So it's not just connected to the front of your body, which is your abdominals. It's connected to like weakness in the glutes. Piriformis might be tight. So piriformis is another deep muscle in the buttock region, which, you know, obviously, you know, from your training, some people might say it's painful or tight or whatever. It's connected to your lower back muscles and obviously your diaphragm. So you've got that box in your body. You've got the base, the front, the back, and the top. And like you said, Keigels is not just tightening these muscles. It's all of them working together.
Accordion.
Yeah.
You know?
Good activation in the core. Starting with the basics, obviously, and making sure your breathing is right and on cue. And yes, to some extent, the start of the exercise will be what everyone thinks a Kegel is, but you need to build up on it. Just tightening and stopping your urine is obviously not enough. And if it was enough, we wouldn't have these problems.
And like you said, it's very important to identify the fact that your diaphragm and your pelvic floor work together, like I just said, like an accordion.
Exactly.
You know, and you cannot distinguish one from the, like not distinguish, but you cannot separate one from the other. They do work together. If you want what you said, this box, or I like to call it the canister. If you want the whole or the kinetic chain to work well together, it starts by the diaphragm and the pelvic floor working harmoniously. And which takes us to breathing, and I want to talk about Pilates, right? Now, a lot of postpartum and pregnant mamas love Pilates. And I'm not dissing it. It's got its benefits.
They do the opposite breath work, don't they, to the pelvic floor?
I mean...
or it's repetitive in some sense.
The breath work does not include a detailed directive of incorporating your diaphragm.
Yeah.
And I actually went to a reformer class one time, and I struggled because I felt like, let's say if both of us had to do the same exercise and I had to, inhale, expand 3-dimensionally, incorporate that, get my diaphragm to drop and expand with my pelvic floor. For me, when I will contract and incorporate my abs, and when you will contract and incorporate abs, that reflex would be different from person to person. Yeah. So for me, if I try to match your speed, I might dome.
Yeah.
I might have a less optimal intra-abdominal pressure. What I noticed was, and I'm going to get a lot of hate for this, but I did not see any mention of the incorporation of pelvic floor and intra-abdominal pressure with the Pilates.
And I think this is where
And just to say, I've done the theoretical part of STOT Pilates. Yeah. What I didn't do was the hours of teaching, because that's not something I wanted to do anyways. Yeah. But I did do the theoretical part of mat STOT Pilates. So I do understand the teaching methodology and stuff. And again, not to diss it, it's almost perfect. If we just incorporate,
it's probably,
I would say pelvic
like you said, it's not the best for these conditions. Might be the best way to say
I mean, again, I have not done, I have not studied prenatal Pilates, so I don't want to diss it before, because I don't have enough information on it. And I've never been to, I've actually done a couple of prenatal reformer Pilates classes. And I noticed that some movements were causing me to dome. And if I didn't know what I knew, I would have created a lot more damage. Anyway. So I think I would love to hear more about what you think of this.
I personally, because I don't work in, more of a gym or an exercise setting, I work on correction. So with my therapy hat on, I'm looking at what's wrong and how to fix it. So in a way, I probably do what you're probably about to get to, which is a combination of things. So my version of Keigels is, after getting you to do these basics of, that we've already spoken about, and basic breath work, I then try to get patients to control their pelvic floor while doing other types of exercises, which can include Pilates, but let's call them Pilates-based exercises, because it's not exactly Pilates.
Because you can, because I remember.
Weightlifting. Yeah. Cardio even. So going back to one of the questions is it just Keigels? It's about how to incorporate them into correct techniques.
Yes.
And how long to do Keigels, again, is a very common question. And normally I always give my patients the example of someone who goes to the gym for weight loss. If you wanted to lose weight or build muscle in the gym and went on a diet, is 1 day a week going to make a difference? Probably not. Is going every day going to make a difference? Yes, but it's probably unhealthy. Ideally, if you wanted to exercise to lose weight or go on a diet, it's moderation. And in terms of exercise, you'd be recommended to probably go most days a week. So maybe 3 to 4 times a week, or even 5 days a week. So I say it's the same for the pelvic floor, because the pelvic floor therapy is based on exercise. It's not going to happen if you do it once a week. And if you overdo it and do it many times a day, every day, it's just going to be too quick and it's just going to fatigue. So exercising or doing exercises for your pelvic floor, if you're doing your own program, probably works best if you do it every other day in an intense setting. And
I'll tell you how I work it. I'll tell you how I work it within our programming. Now, obviously, you know that I do work with rehab and corrective exercise, and I also work with just general strength training and fitness as well. We'll keep postpartum for now and prenatal for now. Yeah, let's just talk about general women that are, I guess all women are postpartum. So postpartum can fall into this category. But the way I would do it is, as part of the warm-up, we do diaphragmatic breaths where, we also engage the TA muscles. Just simple diaphragmatic breaths. And then as part of activation work, whether it's incorporating the glutes or whatever, I would also include diaphragmatic breathing as part of the warm-up exercises. And then with time, especially with my PT clients, because it's a little harder to do that in a group setting, unless the group setting is a little smaller.
They're very similar.
But what I would do is, like, when we do lift weights, it is my responsibility to teach my client how to not compensate.
Yeah,
or
exactly.
Yeah, and
it's all
how
about
to not
technique.
compensate the pelvic floor muscles, because you know what? Down the line, you're going to suffer.
Yeah.
So I teach them to incorporate it with proper intra-abdominal pressure while lifting the weight. So then when we lift, we're improving the stretch reflex of the muscle. We're also, it's like it becomes an involuntary movement.
Yeah.
So my goal is to move Keigels from making it a voluntary movement into an involuntary movement with the right stretch reflex.
You're telling your body, this is what you need to do before doing lifting, or this is what you need to do before squatting or
100%.
lunging. Yeah.
And then the woman's body adapts.
Exactly.
So now when I move to lift, even when I move to lift something from the floor or move to lift my kid, my body naturally, without me consciously making an effort, braces in the right places. Now, going back to Pilates. So when I did try the reformer class, I had to slow it way down. I had to regress a lot of the movements for myself.
Yes.
Because, and I remember the coach came to me and she's like trying to correct me. I was like, I'm doming. I can't do that right now. So I had to correct myself. But this is the part where I think it's a responsibility of most coaches to either educate yourselves of this or hire somebody that has those credentials and try to create a system, make it your own. We are given programs.
You're completely right. And sometimes I tell women it's your responsibility as well to be aware that, you know, who you're going to train, first of all. Yeah. And it's not to say some people are good or some people are bad, but people need to know their own bodies as well. They need to know when they're being pushed. And from my point of view as a physiotherapist, this is not just with regards to the pelvic floor. This is the same when it comes to like back injuries, knee injuries, foot and ankle injuries, you know, like sports-based or gym injuries. So a lot of people who are like trying to get in shape, lose weight, get stronger, they might go to a gym, they might pay someone an insane amount of money to make them look a certain way. And that person is doing exactly what you've told them to. They're pushing you to make you look that way.
Yeah, that's true.
So, yeah, I do understand that, you know,
but
trainers need to be knowledgeable.
But
that
I kind of
person needs
do
to
wish,
be,
though, I agree, there's a responsibility on the
it's on
client.
both sides.
100%. But I feel like there's enough information out there right now to know better.
You're absolutely right. But
and also, I believe, and perhaps it's picked up in other parts of the world, and hopefully it's going to start picking up here, is hybrid work.
Yeah.
I think we've reached a point
Work
where
together.
Yes, it's very important to create hybrid workouts. Like for example, I could be, I'm not trying to I love Pilates, by the way, don't get me wrong. I think it's a very useful tool.
Yeah.
But like, let's say for example, if you're doing a hybrid form of Pilates where you incorporate the things, the protocols we learn.
These hybrids do exist. They just need to be
brought
given to the right person at the right time.
Yes.
So if I give you an example of one of my previous patients who'd come in, very mild pelvic floor problems, 1 year postpartum after the second child, has a diastasis recti as well. So she was overweight because she's put on weight after 2 babies.
Right.
She'd gone to the gym and she's starting to get back pain, and her very mild pelvic floor problems were getting worse.
Right.
And I said to her, we need to slow down. And I gave her alternatives that would be healthy for her pelvic floor now while we work therapeutically on it.
Right.
She was not in agreement because she'd gone to the gym because she wants to lose that weight. And, you know, like you said, the information is out there. It's been given to her by a specialist. So this is not something she's read online.
Yeah.
She's paid money to come and see me, have a consultation, taking my advice, and she did not feel comfortable. And I can guarantee you, patients like, and there's many of them.
No, I agree. I actually have a few clients with the same issue.
Shop around until they find someone who give them what they want.
What they want. No, I agree 100% because I actually do have some clients that come to me with said issues and they don't have the patience it takes to work on fixing the said issue. In fact, they're like, well, you know what? I just want to get, stronger.
We should be educated. Yes, we are. And the information
I
is
mean, one of the
available.
reasons why we're doing this podcast in itself is to educate as many women out there. You know, it's a tough pill to swallow for some, but a necessary one nonetheless.
I think it's the annoying thing is like, I mean, we'll save it to our postpartum episode, won't it? Because that's more about weight gain during pregnancy
But
and stuff.
before we move on, I do want to go over the questions because I want to make sure that we've answered everyone's questions. Would you recommend pregnant mothers to come in to do a pelvic floor exam? If so, at what stage of the pregnancy would it be best?
So from a physio's point of view? Fantastic question. Actually, this is something that's being very topical now in the world of like physiotherapy for pelvic health. So we absolutely recommend that someone gets their pelvic floor assessed during pregnancy. The same way that when you're pregnant, you go and you assess, you look after the baby, you do blood tests, you measure your blood sugar, your blood pressure, you scan the baby. Mum's looked after to a certain extent, although the priority is always obviously the baby. But why not look after your pelvic floor? So I absolutely recommend that someone comes in for a pelvic floor assessment, even if they're just told you're fine. I would not limit it to the pelvic floor though. I'll do the pelvic floor, gluteal region, so buttocks, lower back, upper back, and even like the torso and the chest area, because obviously there's a lot of changes that happen to our rib cage. Women's breast tissues develop. You could start getting some backaches. There are lots of musculoskeletal conditions that could affect you.
Can I just add something to that?
Yeah.
You know, a huge part of birth prepping is upper body mobility. And a lot of people don't know that.
So get it looked after. Upper mobility, when you get really, really stiff in the upper body as well, you could get symptoms coming down your arms. I don't know if you've seen that.
Trigger finger, I had
trigger
it.
fingers, carpal tunnel syndrome, neck pain, headaches. Why wait for the headache to come on when you're pregnant if you could just avoid it? Because there aren't that many medications you could take. So just avoid it. And obviously, like you said, we'll talk about this in another episode, but we could start assessing for abdominal separation. Working on your abdominals during pregnancy is less likely to give you a large separation or a hernia.
But there is a natural separation that happens
so
during
that we're saying
pregnancy.
less likely. It's not. It doesn't avoid it. But you'll have strong abdominals. So theoretically, your recovery should be faster. So it reduces the likelihood. It doesn't eliminate it. Of
course.
I'd actually be worried if someone didn't separate during you need that separation naturally.
Yes.
And vice versa. Someone who's extremely active and someone who has really tight abdominals actually. Like someone who's like, say, an athlete or like an amateur athlete. They're probably more likely to have problems with their abdominals.
Funny
in
story,
pregnancy.
actually.
So being too fit or unfit. It's that extreme.
One of the case studies for birth prep that we came across was of a volleyball athlete. And basically, you know how volleyball athletes tend to extend their spine a lot in order to hit. So they're producing that. They're contracting their posterior chain to create that force to push. So the sacrotuberous ligament is usually hardened on said athletes. And when it comes to preparing them for birth, that is one of the first things they need a pelvic floor PT to work on because they need to release the tension around the region to allow for a slight softening of the ligament to occur to create room for the outlet, for the baby to come out of the outlet.
That attaches to the tailbone. So the sacrum, you know, for our viewers is the tailbone. And you're right. So if there's a lot of pressure coming from top, something below is going to be tight to keep that control. So that's one of the other things we could assess for as well, like someone's mobility, like in the pelvic region.
But that is not just for volleyball athletes.
Oh, no, normal person.
It's
a normal person can have it. So actually, this ligament can tighten in anyone who has a lot of pressure going through their body. It doesn't have to be an athlete. Another actually common example of people that have this ligament tightened, you think this is really interesting or strange, but people that suffer with constipation.
Oh, wow. Interesting.
So that ligament can get really, really tight. Because if you're really constipated and there's a lot of pressure, so it's a different type of pressure. It's not a volleyball pressure, but it's pressure from the feces. So any pressure going through the pelvic floor could tighten that muscle. The second part of your question, Esraa, was when should they come?
Yes, when should they come? So the pregnant women, now that we're talking about the pregnant women, when should they come see you?
Theoretically, there's no right or wrong answer. I think in terms of the safest would be after 3 months or after 12 weeks. Because generally early on in the first trimester, women are very tired anyway. So some of the symptoms they have might just be to do with the first trimester and hormones. Most women have most bodily changes or ligament expansions around the 4th month of pregnancy, which is 14 to 16 weeks. That's one of the first growth spurts, which can cause pain and discomfort around the pelvic region. But I think as a rule of thumb, I would say after the first trimester or halfway through your pregnancy.
Yeah.
And then it doesn't hurt to come in again if you're absolutely fine.
Right.
Generally, the women who come to see me are usually women who have developed problems. I can say...
I came to you because I was curious.
You're probably the only person who came to me without any problems. I've had a few other women who came to me pregnant because like they've had multiples. So let's say they were between their like 2nd and 3rd or 3rd and 4th. They're now pregnant with the 3rd or the 4th. And they'd previously had problems after the delivery of the most current baby.
Yeah.
So they've come to work on their pelvic floor in pregnancy to hopefully avoid the issues they had postpartum with the previous baby.
Right.
Because they're aware now, you know, they've gone from 2 to 3 or 3 to 4 that things might be a little bit worse.
Right.
So I've had more of those.
Right.
And these won't necessarily be nulliparous women. So they're moms. So they're aware. So that's the difference. So these women have been through it. They're aware what sort of problems you could have. So now, and they've realized how long it takes to recover. And now they want to speed up that recovery because they have more than one child.
I'll say my advice to nulliparous women that have never been pregnant is look after your pelvic floor from now. Understand your body, create that awareness, and also prepare your body for birth. I think there's very few people prepare their body for birth.
Exactly. I always use this example actually on like when I do like education sessions or talks or like social media.
Let me reiterate. Not just birth. Pregnancy. Yeah. Women need to prepare their body for pregnancy.
So I know women sometimes say, oh, I wasn't planning a pregnancy or I wasn't getting ready to be pregnant. Fine, fair enough, it happens. But you know, when like most women, before you get married, you go on a diet, you eat healthy, you look after your skin.
Except for me.
Yeah. I mean, women go through a lot of effort to look perfect on their wedding day.
Yeah.
So, and a lot of that effort is aesthetic and exercise-based and food-based. So why don't you do the same before you get pregnant? It's the same. Like you're planning a wedding, and if you're, you know, consciously planning a pregnancy, do the same.
Yeah.
So that's generally what I normally say to women. Yeah.
Okay. So what are things that women could do during their pregnancy to have an easier birth and with the least impact on their pelvic floor?
That's an interesting question. I think one of the most common things would be exercise. If you didn't exercise before pregnancy, start gradually and get help. So if this is the first time you're exercising, go to someone who knows what they're doing. If you're used to exercising, continue as much as you can. Obviously, slow down when you need to, adjust, you know, in terms of breathing, your body temperature, all of that stuff. And again, get help if you're not sure. Keep mobile. Generally, I would recommend a lot of pelvic floor work. Pelvic mobility as well. So like anterior tilts, posterior tilts, some bridging if they can, squatting, lunging. So it can be body weight as well. It doesn't have to be heavy. Walk as much as you can. Swimming does wonders for a pregnant woman. It's really safe for the pelvic floor and the abdominals and the lower back as well. Okay. And from a physio's point of view as well, if you want some advice on, you know, I don't want to say safer because that's the wrong word, but like a more comfortable delivery, there is some work we can do on the perineum. And I don't know if I'm sure you are. So it's perineal massage. So the perineum for our viewers is that soft tissue between the vaginal region and the rectal region. And that's soft tissue that expands during delivery to allow the baby to come out. And that's one of the more common regions where you could end up with tearing, injuries to the pelvic floor, or episiotomies as well if they were elective. So some work can be done on the perineum during mid to late pregnancy. And there are also some products that help with regards to massaging, expanding, and controlling it. And to be honest, I think if it comes to perineal massage, that needs to be more of an intimate conversation with the female and what she needs to do specifically for her body.
Yeah, I mean, also, there's a misconception that when we're pushing the baby out, it's our pelvic floor that pushes it, but actually it's your uterus.
Yeah.
And going back
you need to relax your pelvic floor.
100%. So I think it's very important to highlight that part of the birth prep should also be to use your breath to relax the pelvic floor. Because, most of us tend to work on contracting the pelvic floor because, God forbid, after birth, we have pelvic floor issues. But a huge part of it as well is to learn how to use your breath to stretch out and lengthen the pelvic floor. Of course. And I think that's a very important point to drill in most pregnant women. Secondly, with regards to what is pushing the baby out, it's the uterus, and that's where your breath, along with your nervous system, along with your uterus, works together.
And that's why people don't know, but like when you're having your baby and the doctor or the midwife says, stop now, it's because your contraction is stopped. You shouldn't be pushing when, you should be pushing when there's a contraction, an involuntary contraction of the uterus. And that's why, when like you see it on the movies and stuff, it's not realistic, but really childbirth is not as fast, first of all. And it's just, okay, contractions coming, push when there's a contraction. When the contraction stopped, you need to stop. Otherwise, that perineum is going. But you know what?
That's a very innate thing, though. And this is, from my experience, I've noticed that, I couldn't push when they were telling me to push, because a lot of the times, and statistically, in fact, a lot of the times, the medical professionals, I would say like midwives and OBGYNs, would be asking you to push at a time. Not midwives, less actually. Midwives are a lot more holistic. But let's just say the medical world will tell you to do things by the book.
Yeah.
When birth is a very, very innate, very holistic,
very natural,
natural thing. So when I said the nervous system, the uterus, and a relaxed pelvic floor is important, is because they work together. Now, if I'm in a stressed environment, and hormones as well, because obviously I need oxytocin to allow these contractions to, continue for me to be able to birth my baby. Now, if I'm in a room with like fluorescent lighting and the environment is stressful and I'm being told what to do and what not to do and all that, I'm going to be so stressed out. It's going to interrupt my flow. And one of the biggest things they teach us in our training is it's an acronym called FBS, right? Which is flow, balance, space. Now, flow is when you have to create that flow. You have to work with the central nervous system so that the central nervous system relaxes you, creates that oxytocin for you to be in the flow of birth. Once we're in that flow, then there's balance. Then we start to notice, by touching the sacrum, we can actually tell where the baby is. Without having to put your hands in someone, you can tell if the baby's in the inlet, mid-pelvis, or outlet just by, just pulsating around the sacrum. Also, from sounds, smell, and sensation, you can tell the station of the baby. You don't necessarily have to shove your hand inside a woman in order to know. Or even sometimes it's not even dilation. If you had to ask between dilation and station is always a better piece of information to understand where your baby's at. And it helps birth workers move your body, use your biomechanics and your physiology to help baby navigate down the canal. And I think this is something I really hope it starts to be more and more common in the delivery room, because it's very new to this part of the world. Actually, one of my clients is a midwife, and we have these conversations all the time. And I showed her pictures of my birth, and she's like, "You didn't have a CTG on you?" I was like, "No." "You didn't have a cannula?" "No." But again, I understand if you're like a VBAC and you've had a C-section, scar, and you probably will need just in case, of a hemorrhaging, you might need to. But if you've never delivered before, this is something we can talk about in the next episode. But I do want to touch on it. I guess it falls under pregnancy, so we could. It's something that unfortunately, a lot of OBGYNs specifically, and I hate hating on them, but they look at your pelvis is too small. Well, your pelvis moves. It can move. There's a whole
Yeah.
you know, structure. There's a whole,
I think
like, what would your advice be on that? Like, what's your take on it?
Yeah. I completely agree with you. I think it's different when you haven't had a baby as well. And like you don't know what your body could or cannot do as well. I think obviously, again, without, you know, taking sides, I kind of do see both points of views. And I think when things are medicalized, I know sometimes over medicalizing things is not the best because it creates like stress, unnatural environments, like you said.
But like you said, there's a time and place for everything.
There's a time and place for everything. And obviously there's, you know, there are a lot of reasons for the most natural births, water births, home births, all of that stuff. And, you know, I am
risks
a fan.
As well.
I am a fan of
risks as well.
Exactly,
both
risks.
Yeah.
And I am a fan if it's safe for the woman. But then again, if you look at the other side of the coin, you know, one of the reasons why medical professionals in general who are involved in maternity care, without being specific with who's who, but the reason why they I don't want to say jump to these conclusions, but make these decisions is to eliminate maternal and female risk as well, like you said. So, you know, they are taught shortcuts or algorithms, you know, X, Y, and Z is probably unlikely to lead to a good outcome. Waiting a little bit longer or not monitoring or, you know, doing that could have a negative outcome on either mom, baby, or both. So, and obviously, like, yes, it is a fact.
But
that
on the flip side, it could also interrupt the flow.
Completely, yeah. So,
you know, and that could make things even harder for the woman.
C-section rates have increased, obviously, in the more developed countries. Yeah. And it's a known thing. The more developed a country, the higher the rates of C-sections are now. But equally, there's less, loss.
Mortality. Mortality rates have
success.
improved. Yeah.
Mortality rates have improved, and we're losing less women and less babies. So faster decision making, and I think it's having a balance, isn't it? It's like knowing the risk and what's right and what's wrong, and also being like equally open to these things. So yeah, it's a difficult conversation, I think, to have. And I think in that moment, the obstetricians will probably make the call that they think is more likely to save someone's life.
Like I'll tell you what. I'll explain to you. In my experience, I gave birth at a birth center in the U.S. that was inside a hospital.
Yeah.
So down the hall from my room.
Have birth centers in Bahrain.
Yeah, but the point here that I'm trying to make is because birth centers are looked as a risky establishment altogether by most people in this part of the world. You know, it's like, no, but what if? Fair enough. In my experience, I gave birth at a birth center. However, the birth center was in a hospital. Yeah. And my room had a tub. Yeah. The protocol of the hospital was that I could not give birth in the water. But the second I felt the need to push, I was made to leave the tub, and they moved me to the bed. Now, God forbid, if anything did happen, the OBGYN is down the hall. Yeah. Now,
so it's a setup. So there you go.
It's a setup. So we need the right setup.
You're eliminating the risk through, not the risk, you're eliminating the stress through the procedure. Yeah. But you've got that backup plan, and the backup plan is close physically in terms of proximity and in terms of time. So I guess if you say it that way, then yes. Yeah. But like you said, these are like different facilities, and this is a lot of planning to kind of be able to give you that perfect motherly natural environment, but also to have help.
One can only wish.
One can only wish. I mean, maternity services are ever evolving. I think
Dubai, actually, the UAE is.
I was just going to say, healthcare professionals in this part of the world. You know, a lot of us have been educated abroad. A lot of us have worked abroad. Yeah. Our generation is extremely educated, open-minded, and I think, again, a good thing is the more women you have in these professions, the more likely it's going to change. Very true. Like, you know, maternity care is overly driven by females now. At least I can say in Bahrain, I can't speak for the whole region. But it's driven by females, younger females. You're going to have even more and more of them. So, you know, the more we go through personal experiences, the more we're going to change. Exactly like my story and your story.
Perhaps that could definitely plant a seed. But regionally, at least in the UAE, they're definitely progressing very fast. Yeah. And I think they they just launched, I think that they're launching their first birth center as
but
well.
Don't forget, they also have a higher expat population
Of
there.
course, which
so they
makes
have to cater
Yeah, they do. Of course.
to their audience.
But there are lots of Bahrainis that want it too.
That's true. That's true. No, yeah.
But like you said, it all goes down to re-education.
Yeah, and planning. Like, you know, you have to have, I think to create these facilities, you have to have the resources, and a big part of the resources are the manpower, the education, the facility, you know, the finances as well. But yeah, why not? I think things are ever evolving, so let's be positive.
I couldn't have imagined that both like me and you would be sitting here today having such a discussion that's going to go public for all ears. And
one of the things I've learned, Esraa, is I've got to break the barrier with the pelvic floor. And if I'm comfortable talking about it, then eventually women will be comfortable talking about it, detecting these problems early and getting help. Because I don't want... Because I've seen women who are now in their 50s, 60s, and even 70s and what conditions they have. I don't want our generation to go through that. I want our generation to have fitter pelvic floors.
Absolutely. No, 100%. And I think we're going to wrap it up here on a high note. Thank you so much, Dr. Donna, for being with us here today. Always a pleasure. For our viewers, if they would like to reach you, where can they?
Yeah, so you could follow me on my Instagram. It's by Dr. Dana. And I clinically work at Al Anzour Physiotherapy Center. So it's in Zinj, Bahrain. That's our main branch. And the Instagram to reach that is also and just Al Anzour, which is the name of the clinic. And maybe we can post it underneath the podcast.
We would. Yeah, for sure.
Fantastic.
Well, thank you for being here today.
Yeah, fantastic.